So as I mentioned to you all, this patient here has a potential spinal canal stenosis, a potential of entrapment of deep hip muscles over the sciatic nerve. There are often times where I feel that there's a lack of control somewhere. I'm not sure whether it's the lumbar or is it the hip. Okay, she will say that she can wake up in the morning feeling fine, but once she sit down and stand up to walk, sit to stand no pain, but sit to stand to walk, reproduce some form of pulling that starts from the thigh, buttocks, and then at its worst, it will go down to the foot, okay, or the lateral shin area. Okay, whatever it is structurally, we're talking about movement now. So in my mind, I wanted to produce a stabilization strategy, a fixum around the lumbar-sacral area initially. Okay, so the first thing that we did on your hands and knees, the first thing that we did is something that you guys all know already. That's your tailbone. We want to move the hip underneath, your knee underneath your hip, so you're a bit wide in your hip. That's it there. Okay, and that's a common thing that people do. They go wide because they lack control. A bit more narrower, and this is where you're using your hip. Otherwise, all you're doing is just look it out wide, and it's easier that way. So once you're there already, this is your tailbone. This is your lumbar spine. Don't move here. Move here.
Upwards?
I don't care. Just I ask you to move. So I want to see what movement do you know. Yeah, so she starts moving away from my finger. She's still moving away from my finger. So this lady is moving similar to her as well. I needed her to learn that there, but this one up. Okay, now don't move here. This is a tail. We do this. We do this. We do this. She has no, she's moving here. That is her rib on lumbar that she moves a lot. Therefore, she gets a lot of tension around this area, and it's more common than you guys think. And she's got very tight ropes around here. But guess what? You look at the tonicity of the muscle once it goes down to the lower back here. It's almost non-existent. So this girl never trained this L4 to sacral lumbar muscle groups. Segmental multifidus, paraspinal, long paraspinal, probably not there. Okay, so we have to bring this one up. Stay. Tail, move. That's down, good. Yeah, there. That's a good start. Okay? Now, only then I would say we have learned how to fix some lumbar on pelvis. You ready? Then we're gonna go with, we're gonna say this side because the camera is here. I already fixed them here, you don't freaking move there. Okay, you move here, I'll deduct him again. But okay, now we're training hip as a mover, right? So start somewhere easy. You will just get her to slide this leg, slightly keep the foot contact on the ground, slide the knee backwards. Yep. Yeah. Yeah, of course. Yes, maintaining your fixum. Okay, now when she can, I will have to assist her a little bit. For her, keep this one. Yep, good. Don't use your quads, use your hip. And then you're gonna lift up your foot while maintaining the fixum. But she needs to bring this thing. Yeah. Okay, now she's feeling in her hips. Okay, and then lower down. Lower down. Lower down. Okay, this is one way that you can do. So before they go up into any form of lifted open chain, you get them to slide. So they learn how to fix some lumbar dynamic hip mover. Second one is then we move bilateral as a mover, which is what you guys see. Fix them here. This is your sit bone. You're gonna shift your sit bone towards your heel without losing your lumbar. Okay, so now she's using here psoas, and defibrillatus. And then she's moving up. This is quadruped rocking to this position and then sitting back. She lost a little bit there. Yeah. Okay. And that is the position. So you can imagine when someone asks to do lunges, right? They don't have this stability. They all use here, and they use everywhere else besides the area that you want to fix them. They will end up using quads. They don't use the DP rotators. They don't use their psoas as a stabilizer because they have nothing to fix them on. Their fix them strategy is thoracic extensors and obliques. Okay, which her obliques is okay. She only uses extensors. Yeah. So these are people who generally find sitting quite comfortable. Okay. But when they're having to extend and walk, because they have got no connection here to here, they only use here and here. That's what they will move. Right? So this is only in I will probably call this lumbar pelvic dash over hip. Okay? So lumbar pelvic means that I'm using lumbar pelvic as a stabilizer, hip as a mover. So this one is a very classic one that I'll start a lot of my patients with very early on. Faham? Done. Okay.
Those were 2 exercises, right? The first one.
Okay, so we're gonna go into quadruped position. This is the same thing for point kneeling, but we're resting more towards the legs. We make sure that the lumbar stays and the pelvic stays and the lumbar tuck a bit more. No, the other way. This way. Rip, 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 and then tail tuck. The other way. Tail go. Tail goes this way. Okay, there. Alright, that's as good as you can get. That's what we get. Alright, and then we sit into the hip, teaching her quadrupt rocking. She learned quadrupt rocking. Very good. Okay, now she stays somewhat optimum in this position here. And what we're going to get her to do is we're going to lift up one leg. So move your feet underneath your hips. Feet closer. Feet closer. Yep, underneath. And then we go into up and down. Yep, up. And she's very shaky in this position. Okay. Now I want you to put your foot down there. Yep, good. Alright. Remember this position. And lift up. Remember this position. Okay. Swap side. Up. Remember this position. And remember this position. Okay. Now we're going to start going into mountain climbers. So now go fast. Nothing moves here. This is stabilized. And I want you to 1, 2. Okay. Your position you forgot is here. Okay. And this position is up here. Okay. Then we'll come back to this. And we'll come back to this. Okay. Wow. So she's rounding her lumbar spine. So I maintain this. Okay. Now go up. 1, 2. Yep. Good. 1, 2. Good. 1, 2. So she's learning very hard to maintain this part without rounding. Okay. Now what's more, if I really feel that she don't have much control, what I'll do is I'll put her foot here in a this position here, and then move this foot behind a bit to this position here. Okay. Now this one don't move. Okay. I want you to swap the foot position. 1, 2. Yes, 1, 2. 1, 2. Yeah, lesser of the vertical bounce, more from the hip drive. Go. Better. Good. Go. Can you feel? That's now using here, and you're stabilizing. 1, 2. That's a running retraining. Okay? But where do you feel it? Yeah. So that's what a lot of runners don't do. They end up using, and then when they try, they drive their hip, go up through your hip. They lost lumbar pelvic neutral. They go into rounding, and then they think they're doing it. Right? So don't look down on very simple 4-point kneeling position. It is a very powerful rehab position, and all I did was I trained into contra. I moved the 6 months a little bit more advanced into maybe a bit 10 months where the person is climbing up onto a chair already, right? 11 months is where they're starting to pull themselves up. So that's a 10-month DNS bird dog. We use a contralateral habits, pop, okay? We start with fixum. We learn how to move fixum of the lumbar pelvic. We use the same mover, hip, okay? But we add elements of speed to it after she has learned how to gain stability over that area. And that then can be challenged very aggressively on a fitter runner as well. Faham? Okay, this is FMS. At a